just what I want to go over. And again, many of the previous speakers have gone over much of the outline here on immunotherapy and the new standard of care. And I will show you Dr. Yu's graph one more time. But I will also highlight a little bit more what GD2 is, how it works, and what the different antibodies are, and what advantages or disadvantages some of them may afford, and talk specifically about an antibody that we are using here with that big name, HU14.18K322A, and I will try to describe why that name is there. I promise you I won't try to use that name more than once or twice, and I may stop with K if I get to that. And then look at the clinical trials we are doing or have done with this antibody, looking at some what we think are very exciting preliminary results. And again, here is the curve with the Grand Dame herself, and if any of you have had the privilege of meeting her, she is amazing, because this would not have happened without her persistence. Many others, including Nikon here, laid a lot of the preliminary background, but she's a little pit bull that you just don't say no to very easily. And it's her persistence literally at harassing drug companies and the NIH and others to do what needed to be done. And I think I'll show you one of her slides in a little bit that shows you just sort of how long it took. But again, in the US and really as we've heard worldwide, these results, I've been doing this over 30 years now, and a 20% improvement even after 2 years is absolutely amazing. And so it basically established a new standard of care for these kids. Well, let's back up. I mean, we've talked about this a little bit. The diagram up there in the right-hand corner, for those of you who are chemists, is the diagram of a diacylganglioside, which is what GD2 is abbreviated for. And as we've heard a number of other speakers talk about, it's on the surface of most all neuroblasts. And we think it has something to do with attachment to the extracellular matrix, but not much more about that is known. The problem is it's also expressed on a number of normal cells. And again, other speakers have talked about this, and that also is the problem, because the conventional wisdom anyway is that the peripheral nerves express this, and when the antibody is bound there, it activates complement, and the activation of complement causes the pain. And so universally, all these kids, to be able to tolerate this, are started on basically continuous infusion pain pumps, and it's turned up until they tolerate it. And again, as you've heard, you can give it shorter, as Dr. Chung just described, or you can give it a long time, like the Europeans are doing. Pain is still the issue. And you know, the monoclonal antibody that recognizes this is called CH, and that CH stands for chimeric. What that means is part of the antibody is mouse protein, and the other part is human. And again, I will just briefly go over what we've heard about as ADCC, but I also need to highlight that these antibodies also kill by what's called CDC, or complement-dependent cytotoxicity, and that, again, the antibody binding causes activation of complement, which is a complicated system of proteins in your blood that, again, when the antibody is bound and recognized, it punches a hole in the cell and causes cell death. And here's one of several graphs that we've seen various versions of. And again, I'm sure my little pointer does not show up, but the ADCC is on the top, and that's just an effector cell. And as we heard from, again, Dr. Chung, NK cells, granulocyte macrophages are most of those cells. And again, when that cell recognizes a tumor cell that's bound with antibody, it attaches and causes lysis of the cell. This little, on the cartoon here, little hole is what's called a membrane attack complex, which again, basically, this is meant to represent the activation of complement. and it punches a hole here. And the reason I highlight that is because, oh, and here's another, again, picture. It's worth 1,000 words. This comes from the drug company website that makes dinutuximab. And you see in blue here the antibody with the yellow part, the attachment, and then the cells come and do their duty. And then, of course, with Dr. Chung here, I could not show one of his cartoons and one of his reviews. But again, just highlights that you need the immune system to help the antibody work. And really, when and this just highlights, again, much of the preclinical data suggests that the NK cells are the major effector cells, but again, these other immune cells, macrophages and granulocytes also do that. Okay, these just are several of the anti-GD2 monoclonal antibodies that have been tried in the clinic. We heard about 3F8 and HU3F8. This is dinutuximab. There's a humanized version of that that has been, Dr. Sondel attached IL-2 in his group and have given that, and there's a paper in Journal of Clinical Oncology showing also some interesting positive responses, but with a lot of side effects. And then this is the European version, which basically is identical to CH1418 except for the sugar that are attached to the antibody, and that has to do with the cell that it's made in. And so here is our antibody, HU1418K322A. It was made by a smart molecular biologist named Steve Gillies, and actually we were able to get it through the help of Dr. Han Gretner, which I don't think is here yet. He's supposed to be here tomorrow. He was at our institution for a number of years, and he apparently knew the group that made this, and he arranged for us to get it. We have a facility at St. Jude that can make live products like this. So he got it for us to test and make, and he got it well before the New England Journal paper came out. But it's humanized, and as we hear, and again, I don't think you can see my pointer very well from the back, but these yellow stripes are meant to represent the business end of the molecule that recognizes the cell, but those are the murine proteins. The rest is all humanized. And that blue dot in there is what Dr. Gillies did, because he somehow, I'm not by any stretch of the molecular biologist, but identified the area of the molecule that bound or activated complement and basically cut it out in theory, hoping that this would reduce the pain. And then they also produced it in a different cell line that resulted in a different sugared fucosylation decrease enhances ADCC, hoping that this would make up for the complement activation not being part of it. And you know, the hope was that these advantages may allow more of the antibody to be given. The hard part with this antibody is we don't know what is the best dose. We know probably that more is better, and at some point you probably give too much, but we don't know where that line is at this point. Again, you've seen a number of these cartoons, and this is meant to represent the Children's Oncology Group approach to treatment of children with high-risk neuroblastoma. And we've heard induction chemotherapy. Each of these geometric symbols are representative of a 2 or 3 drug combination. And as you all know, we give that at pretty much maximum doses. And then you have to wait for the patient to recover sufficiently to tolerate the next dose. So roughly every 3 weeks. And in the US, almost everybody gets a cytokine like GCSF to facilitate the count recovery, which is the main thing that holds that up. As we've heard, part of the induction chemotherapy, stem cells are harvested for later rescue in the consolidation phase. And somewhere during this time, surgical resection is attempted of the primary mass. And again, radiation is used later on after stem cells because you can't do a curative surgery. As you know, these tumors are wrapped around lots of important vessels and other organs, and to do a curative surgery in cancer, pretty much you have to have a normal rim of tissue, which is impossible in this disease. Following recovery then, consolidation, which is called myeloablative therapy, and whether you use 0, 1, or 2 is what's up in the air right now, but at least the COG thinks that 2 is better than 1. Then we use the stem cells back here to rescue. And earlier this morning, there was a question on contamination here, and there was a randomized trial looking at when the stem cells were taken out, trying to clean them of tumor. And I guess in my simplistic way, if one cell escapes the procedure, they probably will recur. And actually an early study at St. Jude pretty much proved that. They took an aliquot of the stem cells and marked them with a retrovirus. And there's a paper in Blood showing a number of patients who relapsed following this stem cell transplant, and they had the marked retrovirus in their relapsed tumor, meaning it came out of the freezer. So the problem with the purging, as an aside, is probably we aren't perfect, and that's part of the issue there. So this is the current treatment approach, and then following all of this in the medical lingo is called in treatment of minimal residual disease. Again, we throw the kitchen sink at these kids trying to get their tumor down to the lowest possible burden, and then following that, this complicated immunotherapy is given. And again, when the trials, the registration trial, which I think was designed in the 90s, it took that long to get it through, the dogma was giving chemotherapy with immunotherapy, as again Dr. Chung has already alluded to, is counterproductive because you need the immune cells. And so that's sort of where we were. And again, I stole this from Dr. Yu on the web, but this just shows that it took 26 years to go through this procedure from the time that the first phase 1 trial was started with this antibody to get it through all the various trials that led to approval. And again, Dr. Kern earlier today did a nice job of sort of explaining that process, but it just takes a long time to do it, and it's frustrating for mom and dad out there because this doesn't, if you have a new medicine today and you want to use it here in your loved one, that's the frustrating part. And again, here we are, back to Dr. Yu, and after she presented her data one day at the Children's Oncology Group meeting before it was published, I just went up to her and say, okay, now what? I mean, we're still losing half of the patients. Where do we go from here? And she said, well, you give it with chemo. And so that's what we did. And we'll go, as I learned more immunology, there have been a number of strategies to try to improve the response that Dr. Yu's group and have used. One we've already heard about, interleukin-2 and GM-CSF. And again, these are used to augment the ADCC. IL-2, whether or not it works, I think, has a lot to do with the dose that's given. And then, again, this was a chimeric antibody, so humanized, whether it's humanized 3F8 or HU1418, in theory, should result in less allergic reactions. And then again, the K322A had a single point mutation, and that's what the K to the A means, to reduce the complement-dependent lysis, and in theory, should cause less pain. And then what needed attempted next, according to Dr. Yu, was to combine it with chemotherapy. And again, in the last 20 years, there's been a whole lot learned about immunotherapy, and that chemotherapy, some of the agents we use every day to kill cells may actually be using part of the immune system to do their dirty work on the tumor, and that they induce what's called an immunogenic cell death, so that it disrupts some of the strategies that tumors use to evade the immune system, suppressor cells, other things. The other thing that we had the unique ability to do, and again, Dr. Chung alluded to using NK cells. We had a world's expert at our institution when we were designing this trial who was harvesting natural killer cells from parents and using that in AML and several other trials at our institution. So we made use of this expertise, and I'll show you that in a minute. And then we went ahead and used IL-2, again, after chemotherapy, because it is one of the growth factors that NK cells like. It keeps them happy and activates them. And then GM-CSF, and again, I'm echoing Dr. Chung's name, but and I don't think enough credit is given because he started this whole thing. But he has a very convincing paper in showing that GM-CSF, when given with the antibody, enhances its effect. And the other thing we know about GM-CSF is it's a cytokine that also stimulates your normal white cell recovery, so you can use this in place of Neupogen if you want to prevent febrile neutropenia or reduce how long you're in the hospital after you get neutropenic and fever. So again, as most new agents, you have to go through a phase 1 and a phase 2 trial, and this is just the St. Jude mnemonic for our single agent phase 1 study, which Dr. Naveed at our institution ran, and this was using HU1418K as a single agent given daily ×4, which is how dinutuximab is given. And the MTD means maximum tolerated dose, so the goal of the phase 1 trial mostly is to find out what's a safe dose. That's what MTD means. So most patients could tolerate 60. And just to give you a background, the dose that's used in the New England Journal paper of dinutuximab is 17.5 milligrams per meter squared. So at least our phase 1 study seemed to indicate that this engineering of HU1418 may have helped in allowing us to give more. And again, we saw a number of responses, again, in a single agent. The other thing that we noticed clinically is that these kids seem to be having less pain, as we would have hoped. And because we were also enrolling patients at the same time. Again, phase 1 studies are studies that you do in kids that have failed everything pretty much. So new patients, we were putting on the COG trial, the 0032, that was the result of the New England Journal paper. And our impression was that they seemed to be tolerating the phase 1 HU14K better. And one of our anesthesiologists who heads up the pain team said about basically documenting this. Again, this is retrospective. As we heard today, the best way to do this would be a randomized trial, but I don't think anybody wants to waste precious patients to prove this. But we compared 9 patients who were getting dinutuximab in the complicated recipe that we've heard some about to 19 patients on the phase 1 trial, again getting doses. We didn't even look at the lower doses. We said, if this pain is going to be real, it's going to be at the higher doses. So we only looked at the kids that got 40 or above, 40 milligrams per meter squared above. And she basically counted up all the doses of narcotic they got. Again, part of our pain team management, the pain team gets pain scores, and many of you may be familiar with that, but they're little happy faces or sad faces that the kids can point to as where their pain is on that day. And very convincingly showed, and for those of you not familiar, a p-value means how our statisticians tell us that this is not a statistically significant difference. So a usual number is p less than 0.05, and all these numbers on overall dose, day 3 or day 4, were at least convinced us, as was our already clinical impression, that the kids were tolerating this better. And the other thing that I didn't highlight here is we start out the HU14/18K antibody at 4-hour infusions. Typically, dinutuximab is started at a 10-hour infusion because the kids can't tolerate it slower. And then many of them need to extend it to 20 hours. So with that result, we said, how can we get this into new patients, this antibody into new patients with Dr. Yu's encouragement to give it with chemotherapy? So we had to prove to ourselves and to our institutional review board that this was safe. And so we designed a very small pilot study to show that we could give this antibody with chemotherapy. And I mean, you know, the cyclotopotecan is a 5-day infusion, the way or 5 days of chemotherapy, the way the Children's Oncology Group gives it. And we started antibody on day 2 through 5. And I won't go through all the iterations of when this started, because there's quite a bit of work and discussion that took. And then we followed the chemotherapy instead of G-CSF with GM-CSF, hoping that it would improve ADCC and also prophylax against febrile neutropenia. And then we give what I would call low-dose IL-2, sub-Q injection, 1 million units, which is much lower than the Europeans are using, every other day for 6 doses, hoping that whatever NK cells were left would be happier. We only treated 13 kids, and the interesting thing, 9 of these kids had had prior exposure to dinutuximab. And you know, this is the complicated, but really in colors, we gave 6 cycles of chemotherapy, cyclophosphamide topotecan for 2 cycles, irinotecan temozolomide, and then what we call ICE, which stands for phosphamide carboplatinum etoposide, a commonly used regimen, at least in the US, for relapsed solid tumors, neuroblastoma. And then we gave antibody, as I described, with every course, and we give antibody with parental NK cells to the other course, and also basically designed this study not to find out does NK cells work, but to find out could you give it to patients safely. And we identified no side effects to NK cells. And again, everybody, again, this is a heavily pretreated group of children, so it's not surprising that everybody got severe myelosuppression, mild pain, and part of that I think is antibody. The other part is we started narcotics with the start of the antibody infusion. And again, we saw a number of very promising responses, including 4 complete responses. The median time to progression, again, in a relapse setting like this, it's much shorter than that. I don't have time to go through the data, but there's a COG paper that they looked at the time to progression on patients, and this is much longer than that. So again, the goal of this trial was to say, hey, this is safe. Let's not wait to do another phase 2, whatever. Let's just give it to new patients, and that's what we did. And the goal of our trial that we've called MB 2012 was, could the addition of this antibody, when given with induction chemo, improve our response rate? So, you know, the gold standard would be a randomized phase 3 trial, which would take the whole Children's Oncology Group 5 years to do. And as we've heard, they've had a lot of work in MIBG, and that was going on. So next best thing is what we call a historical comparison trial, in which we look at a group of very similar patients that have been treated in the past with identical therapy, and say, if we tweak this treatment by the addition of our antibody, can we improve what we call objective response rate? Again, I think it was Dr. Cairns who tried to explain what this means, but it basically shrinkage of tumor significantly. This is not cures, which is what we're all interested in. And again, this is the outline of that trial. This was what was the pilot trial for the just to closed Children's Oncology Group trial with the tandem transplant out here. But it had identical chemotherapy. And so we wondered, and that 40% response rate, 12 of 30, was measured right after these 2 cycles of cyclotopotecan. So this was our historical comparison. And I put this slide up here because I wanted to remind myself, as you've seen everybody else, these trials are not done, you know, by one lone ranger. It's an army of people. Both my oncology colleagues, our surgeons, our radiation therapists, our bone marrow transplant team, nurses, obviously Dr. Gillies, who made the antibody. And we couldn't do that without, and as well, what is the courage of our patients and families to try something new. And so this statistical plan, we wanted to say, hey, if we add the antibody, we want to see a big jump in that early response rate. So we said, you know, the early response rate was 40%. If it improves it to 60%, that's going to be interesting. People will take notice. And so we went to our biostatistician, and he designed what's called a group sequential design. And the goal was we didn't want to carry on with this trial if it looked early on that it wasn't going to work to that degree. And so what that means is that in the first 20 patients, if less than 7 patients had at least a PR, then they would, we would stop the trial early. So this is just a cartoon comparing MB12 in the top, and that's really the initial response that we compared. It's not randomized. We took the response that was in the publication. The other things that we did in the design of this, we gave the antibody with every course of induction. We also gave it immediately following a stem cell rescue with parental NK cells. And then in MRD, we used our antibody with an identical recipe that Dr. Yu's paper showed. And this just shows that the patients in AMB02P1, the pilot study, were very similar to the patients we put on MB12. Most of them were older with metastatic disease, INSS stage 4 disease. About half of them had NMIC amplification. So a very high-risk group of patients. I'm getting shown 2 minutes, so that it was very well tolerated. Although, and again, many of these patients, as you only too painfully know, present with widespread metastatic disease, but we could get away with giving it. They tolerate it well. There's a learning curve to giving it. And this just shows some of the responses. And again, black is bad. These spots are all tumor. And here's a diagnostic MIBG scan. And following 2 courses of therapy, this is just your normal, you're peeing it out, and it also taken up by your salivary glands. And these are SPECT images with the yellow spots being tumor in the spine that are all gone. And this is only following 2 cycles. And when I first started seeing these, I said, you know, something, you know, we got lucky with the first patient, and then the second and the third, and it, you know, here's another example, lots of tumor in the bone marrow that goes away after 2 cycles. And this just shows the primary tumor shrinking in a similar way. And we're stuck. Well, magic fingers. Okay, and this just, again, highlights the responses. A 12 of 30 in our historical comparison, 32 of 42 in that first cohort, which is basically double. And obviously, these are early responses. We hope that translates into cure. We have to wait. The other interesting part, this is a watershed graph. Down means shrinkage of the primary tumor. So our radiologist measured the volume of all the primary tumors at diagnosis compared after 2 cycles. And this magic line is roughly what would constitute a PR, but you see everybody had a response except one patient who had a 5% growth. So again, this was very gratifying. Because of time, I don't have much time to go through what we call the Curie scores, but on both sides of the Atlantic, they count the spots and have shown at the end of induction how many spots you have. They do it a little bit differently, divide the body up a little bit differently, count the primary tumor as a spot or not. But the bottom line is if you have in the US what we call a Curie score less than or equal to 2, those patients at the end of induction, so in the COG, that's after 6 courses, they do much better. And the SciPen, Dr. Ladenstein just published a paper just recently doing a very similar thing both with the COG cohort and a SciPen high-risk group. And again, the patients who had less than 3 spots did much better. So we wondered, could that give us an early indication? And again, MB12, our median Curie score at diagnosis, was very comparable to the COG number of patients. At end of induction, our median is 0, and only 4 or about 11% had Curie scores over 2. So we hope that means that these early responses will translate into more cures, but the frustrating part is we have to wait till patients get out far enough to understand that. But really, to summarize, it's well tolerated when given with chemotherapy. Everybody had a clinical benefit, and we think these Curie scores at end of induction are very encouraging. And we're continuing to accrue patients to get a better handle on whether survival is really going to be improved. And clearly, I think these data really warrant a larger cooperative group trial to find out if it's given with chemotherapy, will it translate into more cures? And I think that's all I have. And here's 3 of our friends who had neuroblastoma. That's all I have. I'd be happy to take questions.